Well, I'm Ed Welch, President of the University of Charleston. As most of you probably know, welcome to the University of Charleston. We are bursting with pride these days because we have the highest full-time enrollment in the history of the school, but also because today, for the first time in the history of the school, one of our athletic teams is rated #1 in the country. And that's the men's soccer team. UC Speaker Series is sponsored by Dow Chemical Foundation. Tyler London is the head of Dow, West Virginia. And this is year 14 that they have done that. So it's great for us and great for the community. Silence your noisemakers, please, so that they don't interfere. And we will are giving you the opportunity to write out questions you would like to ask to these experts who surround me. And after I give them a few questions, we will throw your questions at them as well. This is a conversation. It's not a debate. We're looking for information and give these two individuals a chance to share. On my left is Steve Dexter, the CEO of Thomas Healthcare System. He has been the CEO there for 20 years. He had some experience as a CEO previously at Humana Healthcare System, a major national healthcare player. And I just discovered that he and I share an alma mater at Boston University. And on my right, David Ramsey, CEO of Charleston Area Medical Center System. He has been here now for 14 years, was previously the president of Methodist Healthcare in Memphis, and did not go to Boston University, but Washington University in St. Louis. And in transparency that is required these days, I share with you the University of Charleston works closely with both of these hospitals with our healthcare programs. So I want to begin by asking each of you to say a word about quality of healthcare. Is the quality of healthcare in hospitals any better today than it was 5 or 10 years ago? And if so, what's the evidence and why has it gotten better? You want to start?
Sure, I think the answer is yes. I think it's gotten much better. I remember sitting in a meeting about 15 years ago. There were 200 hospital administrators in the room with their chiefs of the medical staff, and it was right after, is this too loud or? It's okay. After one of those books had come out about infections, and the guy on the stage says, what's your central line infection rate at your hospital? And we all looked at each other. Not one of us knew what it was. So Chief of Staff and I went back and said, let's find out. And it took me probably 3 weeks to figure out what it was. I said, I want to know how many did we have as the denominator and how many were infected. And when I finally got the number, I said, that's a real problem. And so we started working on it, and now it's less, it was probably 15–20%. Now it's less than 0.5%, and we're still trying to drive it less. And I think that's just one example of the focus we put on quality, at least in my 20 years in Charleston.
Mm-hmm. David?
Well, I agree with Steve. There's no question that quality in the hospital environment has improved. Probably over the last 10 years significantly. The next speaker in this series will be here November 11th. He's with an organization called IHI, Institute for Healthcare Improvement. And that organization has done a nice job of really leading the healthcare industry in quality improvement at the hospital level. So without doubt, thousands of people's lives every year have been saved through really quality improvement on a national basis.
Hospitals are filled with metrics these days. What metrics, in your mind, are the best indicators of hospital success? Length of stay, outcomes, financial metrics, balance sheet? What do you really look at as being one or two things you really want to follow and track?
I'll let Dave take this one first.
Well, my chief financial officer is in the audience, so I have to be a little cautious here because he would say we should track the financial metrics And we do, of course. There's an old saying in healthcare, no margin, no mission. In other words, if you can't be financially stable and successful, then you're really not going to have a healthy organization. So clearly, you have to be financially viable to function and offer the services we offer to the community. As Dr. Welch, out of an abundance of letting everybody know everything, he's on the CAMC board. He also chairs the quality committee of CAMC, which is not really fair in the overall scheme of things because he knows a lot of good questions to ask. But I'm also on his board, so paybacks are hell.
That's true.
Anyway, in our organization, our finance committee meets every other month, and our quality committee meets every month. So while we certainly spend time looking at the financial performance on a monthly basis, we look at our quality performance, and in our board meetings, I would say we spend more time, probably 3 to 4 times more time on the quality side of our operation than we do on the financial side of our operation.
You're saying I'm for both, are you, or no?
You just have a lot of good information to share.
Echoing Dave, there's a lot of metrics we look at. We have, for quality, we have a quality dashboard, and it's color-coded. Red means we need to fix it. Blue, we're top in the nation. And there are, I bet you there are 70 or 80 metrics on that we look at every month. The way we're structured, we have individual boards at both hospitals, and those hospital boards, they look at the quality metrics and they look at the credentialing of the medical staff. That's their entire function. In terms of the financial indicators, as Dave said, I used to work for a for-profit, and I once had a boss, and they're not bad, but he said, your job as a CEO is to maximize shareholders' return on equity. That's what they told me when I joined the company. Now, we do that by delivering health care, taking good care of people, but that's your goal. And here, when I met with my board, they said, your goal is to take care of this community. You know, our family comes here, our employees come here, our friends come here. But as Dave said, you've got to have the financial resources to make sure you have the well-trained doctors, you have the most up-to-date equipment, you've got enough staff on the floor. So we track probably the normal metrics that any business or organization would track to make sure you can stay in business and continue to grow.
Folks in healthcare and folks in other areas of our society complain sometimes about government regulation and interference. It would be my observation, though, that federal regulation has played a positive role in encouraging or forcing hospitals to improve their quality. Would you agree with that assertion? Has that been one of the drivers to improve quality in hospitals?
I think so. I think it's been a real plus. It's good to have somebody from outside the organization look at you. When CMS runs Medicare, when they give you your data, they can compare you to like hospitals across the nation. So you can say, okay, we have a metric and we're sitting here, and by yourself, you have no idea if it's good or not. And you may say, wow, we're in the top 10% of the nation. You know, we can still work on it. Or, wow, we're in the bottom 10%. So I think it's good to have an external source that doesn't really have a bone to pick to look at your quality data to give you those benchmarks.
Okay. Want to add anything?
You covered it.
Okay. And we agreed. We don't both have to answer all the questions if so. One of the bugaboos about healthcare is cost. Our appetites for healthcare and what we want seem to exceed the budgets that we have and the dollars that individuals are able to spend on healthcare. Where do you see all this going? How do you see it playing out? Do we continue to demand more and more technology and more treatments? Is anybody going to pay for it? Or are we going to have to limit care? What's going to happen?
We could spend the next hour talking about this. Right now in our country, we spend about $3.8 trillion with a T dollars on healthcare. And it continues to grow. It's almost 20% of the gross domestic product. When they do, I don't know who they are exactly, but when they look at healthcare, they say that 10 to 15% of the healthcare dollars being spent impact people's health nationally. So the bigger determinants of an individual's health are their behaviors. Do they smoke? Do they drive without a seatbelt? Do they drink and drive? Their genetic makeup. Do they have good or bad genetics? Are they obese? And then their other environmental factors, social factors, like their where do they live? Do they have access to food, and their education level? That those really have an 85 to 90% impact on an individual's health. And it's not so much the dollars that we spend as a nation on healthcare. So it's a significant dilemma. The other thing moving forward is really being driven to a large extent by the Affordable Care Act, Obamacare, ACA, whatever you want to call it, is a movement towards, and we've already seen it, but it's moving at a very rapid pace now, of the individual paying more for their health care out of their own pocket as opposed to the insurance company paying the bulk of the care. What we anticipate happening over the next couple of years is that virtually everybody will have a health plan that's a 60-40, that the individual will pay 40% of their health care cost out of their own pocket. So health care costs, I think, will continue to rise. Like 78 million people over the age of 65, the baby boomers. If you live to 65, you will probably, on average, live to 84, and therefore a lot of older people, a lot of chronic health conditions, so we're going to spend more as a nation. But then the government really is saying that we want the individual to have more skin in the game by having to make more decisions about where they spend their health care dollar. So I personally think we're going to spend more as a nation on health care. We may spend it a little differently than we do today. I think hospitals will be impacted by that. We already see that with more care going to the outpatient side of things. And then individuals, the consumer, will have more say-so about how they spend their health care dollars because it'll be coming out of their pocket.
So if you follow that logic and we have more of the healthcare dollar being spent by the individual, doesn't that just lead to a discriminatory two-tier system in which those people who have more financial resources get better health care and others are left out?
I think there's some truth to that. I mean, if you have money, you have access. That's part of the Affordable Care Act, was to at least bring everybody to a certain level, because if you do not have health insurance, the data all shows you're not accessing the healthcare system. And a couple of quick examples. We had a lady who came into our emergency room about 6-8 months ago. She had stage 4 breast cancer. I mean, when she walked in the room, you could actually smell that she had cancer, and it was growing outside of her. And you couldn't do anything. And they questioned her, why did you wait so long? And she said, well, I didn't have insurance, and I was hoping it would get better, and I was putting stuff on it. So that's a person who, because she didn't have insurance, didn't get cared for. Now, if you get everybody on Medicaid, at least they'll come in. Now you're going to have a hard time finding physicians that can afford to see you, because physicians are in private practice, they have bills to pay, and the Medicare reimbursement is so low. We tell new doctors when we recruit them into private practice, if you take more than 7 or 8% Medicaid, you're probably not going to be able to pay the bills. So yeah, I think that's a reality. If you have resources, you're going to get better access. But at least you got to raise the floor so everybody can have a mechanism to get into the system.
Steve, I just want to comment on one point Steve made, which is an excellent one, and that is that just because you have insurance doesn't mean you have access. Around the issues Steve pointed out, we would all in this room love to have Medicaid because it pays 100%. There's virtually no co-pays or deductibles. It's like the insurance of old, we all remember 20 years ago. And but you may not have access if you can't find a physician who will accept your insurance. That same situation will probably begin to evolve now with these 60-40 health plans, where you'll walk to your doctor's office just as you do today, and they will ask you for your payment up front. in some form or fashion, and that payment up front will start to get bigger and bigger and bigger.
Both of you mentioned that interesting phrase about affordable health care and Obamacare or affordable care. Yeah, a year ago this time, everybody was singing the blues about how fearful it was and how terrible it was going to be, and now there seem to be both positives and negatives. Can you share with us your perspective on what are the good outcomes from the Affordable Care Act and what are the challenges?
Sure, actually I expected that question. I found if you say Obamacare, everybody, boom, they go to their corner. You know, all the reds move over here and all the blues move over here. So I try to call it the Affordable Care Act. And then I try to talk about specific parts of it where you can say, let's talk about this policy issue. So for me, first of all, I have 2 kids in college. One's 25, one's almost 23. I like it because they're still on my insurance. That's a real plus. My other son has a condition that would not allow him ever to get health insurance on his own. And he's sort of, in my mind, maybe of the 3, the entrepreneurial one. So he would always have to work for somebody else to get health insurance before this came up. So personally, those are real positives just for my own family. I think the Medicaid expansion has been a real plus because what we found in our emergency rooms, January 1st when we had the expansion, it was almost like throwing a switch. Our number of uninsured in the ER dropped, and our number of Medicaid, it was almost a 1-for-1. Which I said, okay, that's good because at least now they've got some coverage. But I was hoping to see more of a growth, and we're starting to see that where more people are starting to access it. So I think that's a real positive too, giving people the opportunity to at least have something so when they feel comfortable at least coming to our ERs. On the downside, the way the Affordable Care Act was paid for, it actually reduces the national deficit. Is they took it out of the provider's payments. So they reduced all of our payments pretty substantially to pay for it, and now we're getting some of it back, but it's not equal. And then the other thing, the Cadillac tax that they're putting in there, it's almost like every plan is becoming a Cadillac plan, and I don't think that was the intent. So if they fix one thing, I hope they take a second look at that. So sort of long-winded answer, but.
It's, I can't remember how many thousands of pages it was, but deserves probably a long response. David, what would you add to that?
Well, there's the challenge for us in the healthcare environment is that, to Steve's point, there's some good aspects of the Affordable Care Act. There's some bad aspects of the Affordable Care Act. Our problem is just dealing with it because the 2 parties in Congress can't get together to try and work out what looks good going forward and what doesn't look good going forward. And then we're just stuck trying to work it out at the level of taking care of the patient and running the institution. So hopefully, at some point in time, the 2 parties will decide that this is not the political hot potato anymore, and they'll come together and try and tweak it to make it work the way we'd all like for it to work. They changed Medicare or Medicaid regulations practically annually, and nothing has been done with the Affordable Care Act going forward.
On the issue of cost, I read that a mammogram in New York City may cost less than $100 or more than $1,700 for the same procedure. And there are lots of other examples where the charge for this procedure in one locale is very different from another, and for all I know, the hospitals could be across the street from one another. How in the world does that make sense? And how can patients who are paying bills have some confidence that pricing makes sense?
Yeah.
I took the last one.
I'll let you answer that question.
Let me answer that one. No.
I don't think it makes no sense. It makes no sense whatsoever. It's insane, the pricing system. In West Virginia, we're one of 2 states where the state government actually has to approve our rates, so there's some protection here. When I left Florida, as an example, 20 years ago, I came here, we were charging about $6,000 for cataract surgery, and I got here and we were charging $3,000. And I still sort of had this for-profit mentality. I said, Charlie, double our rates. This is insane. You're leaving money on the table. He said, you can't. You're in West Virginia. We can raise it 2.5% because that's what the government says. But between what the costs actually are to produce the service, what you charge, it's been built up over 65 years at Thomas and 100 years at St. Francis, and I can't tell you there's any rhyme or reason to it at all. I hope, David, you can make it a little more palatable than that.
Well, unfortunately, you kind of get into the weeds a little bit here because it is a very complicated matter. Virtually every hospital has managed care contracts with Blue Cross, Aetna, Cigna, et cetera, and all of those are based on their charges. So what hospitals historically have tried to do is they've tried to raise their charges as high as they can so they can give big discounts, so they can give a 40% discount to the insurance company. Now, we can't do that, to Steve's point. We can't do that in West Virginia because the state caps what we can charge for an inpatient stay or for an outpatient visit. So if you go outside of West Virginia, pretty much every state's basically the same in terms of the hospitals will charge as much as they can and then try to give as little discount to the insurance company as they can. Now, let's talk about the charges overall and the cost shift, the hidden tax that if you have commercial insurance, Medicaid, Medicare, and our state PEIA pays below cost. So that means that in order for the hospitals to be able to operate financially, or doctors' offices, or really anybody in healthcare, pharmaceutical, just take your pick, the costs get shifted to those that have commercial insurance. It's a hidden tax. You know, you're not being taxed directly, but you're being taxed, and therefore your insurance keeps going up. Now, I would suggest that that's one of the huge issues of the Affordable Care Act as well, is that if government pays less to providers, which is how they're funding a big part of the Affordable Care Act, because the idea was everybody has insurance, nope, there's no bad debt or charity, so hospitals don't need all this money, we're going to cut out the amount of money we give hospitals, and we'll give it to individuals to buy insurance. Well, there's lots of problems with this, but one of them is that people end up with a 60-40 plan where they're paying 40%. That means they're not paying anywhere close to cost. They're paying 40% below basically what amounts to something approximating cost. So that just means it's going to be more of a cost shift going forward to the commercial people that have commercial insurance. You know, it's an issue that all of us in this industry deal with everywhere. And so the mammograms, my estimation is that for commercial insurance folks, they're going to continue to rise. I mean, our industry is broken. The financial system is broken. And how we repair it going forward, I don't really have the answer to.
Well, maybe I'll give you another question that's not so easy to answer. One of the complaints or one of the factors in the cost of health care are tests. And the experts say we do too many tests on people. But the doctors want the tests so that they can protect themselves from being sued. The patients want the tests because they want to know everything they can know about their conditions. How in the world do we find the proper balance for how many tests somebody ought to have?
I guess it's my turn, huh? That's a tough one, too. I look at our ER. At Thomas, we have about 100 people come through every day, and they want to get in, they want to see a doctor, and they want to get out. That's why you go to an ER, not to see the registration clerk, not to see the triage nurse. You want to see the doctor. And they've got, I've been there 20 years, 100 patients every day, and they know they've got to turn them over because there's another line behind them, and they have maybe an hour and a half. They got one shot. They've never seen this patient before, and they got to find out what's wrong with them. And so they've got to order these tests, and if they miss it, they know, number one, they could have a patient that goes home and dies, and number two, they could get sued. So the entire system is focused on getting that patient diagnosed, getting them through, getting them what they need, and getting them out. the patient, as you mentioned, if they're not paying the bill, they want to know what's wrong with them. They don't want to go home and say, well, he forgot to order this, and I'm sure you'll get to Ebola, but they sent that patient in Texas home. And and everybody goes, how could they do that? Well, that hospital probably had 200 ER patients that day, and you might have had a new nurse at triage. And so I'm not sure what the answer is, but right now, when you don't have the patient paying for the test and everything is focused on, you can't miss, as a doctor, you cannot be wrong once or you're in trouble. With that kind of pressure, that's the incentive.
Okay.
Dave, you want to add anything to that one?
Well, I would just add that whoever they are, believe that 20 to 30% of what we do in direct patient care is not needed. That's somewhere, they say, between 500 billion and 750 billion. So a big focus, frankly, of what we're seeing happening now in healthcare in the hospital, and a lot of it came out of the Affordable Care Act, are what they call demonstration projects and innovation center projects and so forth, focused very much on trying to eliminate the low value sorts of tests and treatments that we do in the industry. For example, readmissions has been a big issue in our country in terms of people would go home and then they would come back to the hospital fairly frequently. Now, so there's been a big interest and push on the part of hospitals and what we call post-acute care providers, nursing homes, home health, skilled nursing, rehab, et cetera, to try and keep those folks in the environment they're in so they don't come back to the hospital. Well, that's a waste if they come back and yet they could have stayed home or stayed in the nursing home environment or rehab facility. So a lot of work is being done across the country now on trying to eliminate that waste that we all know is in the system. You go to one doctor and have something done, you go to another doctor another month or two later, they order basically the same lab tests or whatever. Well, if we had systems that talk to each other, could they eliminate having to do that? That's a simple example, but that goes on every day.
Let's switch gears and talk a little bit about patients. Once upon a time, patients had the perspective that physicians were godlike, and you would go and you see the physician, and whatever the physician says, you salute. Now there's more of a feeling that patients have to look out for themselves. There may be more up-to-date information available on the internet than is available in the physician's head. If you go to the hospital, it's helpful for you to have a patient advocate who's looking out for you. How does that change, impact what's happening in hospital healthcare? And are those changes legitimate? Are the perceptions accurate, inaccurate? How do you feel about those observations? Might be your turn.
I thought it was his
Is it
turn.
my turn?
Oh, okay.
I thought it was.
I think they're great, personally. I mean, one of the issues in this industry is that the individual's been divorced from it because somebody else was paying for it. And of course, we've only had the really significant internet capability for, 15 years, 10 years maybe. So having the patient involved in their care is you get a much better outcome, should be less expensive. If you have a family member involved with them, to help with understanding the process and situation and the doctor's orders and recommendations. I think everybody benefits from it. I think it's safer care. I think it's better care. I think it's less expensive care with a better outcome.
I concur.
In hospitals, how much access should families have? Should they be in the room 24 hours a day because it reduces falls? Or is that interfering with the care the hospital wants to give them? Should they watch surgical procedures maybe because it might reduce lawsuits, or does that interfere with good care? What's the role of the family in providing care?
Personally, I think the family ought to be with the patient as much as possible. And you have the caregivers, particularly the the nurses that are working with the patients. They've got some pretty difficult things to do, and they can do the job, I think, more comfortably without the patients there. I mean, without the family there. But we really like to keep them, even in the ICU. You got somebody that drives in from 14 hours away. They want to see their dad, even if it's not visiting hours. Let's see if we can accommodate them. We found when the family stays with the patient, falls go down, because a lot of the seniors, they get confused and they get up in the middle of the night to go to the bathroom. They don't know where they are. You can't have a nurse in there with them 24/7, so I think that's a plus. As Dave mentioned, having sort of an advocate with them when the caregivers come into the room. Example of my son, he had to leave town and he went to one of the top places in the country. And 5 times they tried to put him on a med that he couldn't take. And this is like U.S. News and World Report number 1 or number 2 in the nation. He can't take Tylenol because of the underlying condition. And they came in, here's his discharge med Tylenol. I said he can't take Tylenol because of his liver condition. And then resident came in and they said, we're going to give him Tylenol. I said he can't take that 5 times. And truly, and they did a wonderful job. I mean, they've changed his life, but you've got to be there because there's just so much stuff going on. Yeah. So I think to answer your question, the more the family can be there, having them watch surgery, that could be pretty gruesome. I've seen maybe 3 or 4 surgeries and tried not to pass out myself, so I'm not sure I'd go that far.
We have some great questions here. We'll just take turns maybe. With the Affordable Care Act in place, how devastating do you think it would have been if Governor Tomlin had not expanded Medicaid in West Virginia to take advantages of the Medicaid Affordable Care Act?
Well, it would have been significant. We're still going to be devastated going forward. But the benefit was that, as Steve said, more of our patients that we were already seeing now have some form of insurance. So our bad debt collection rate in our situation improved from like 2% to 16%. I think I have those numbers right. Now, the catch-22 of this is that next year, Medicare is paying us $2.2 million less than they pay us today. Almost half of our patients are Medicare patients. I'll have my employees want an increase in salary, the vendors want an increase in drugs and in medical supplies, and the utility costs will go up and so forth. And half of my patients are with a insurance company that's going to pay me less, yet nothing stops going up. Now they're doing that again because the idea is everybody's going to be insured and there's not going to be any more bad debt in charity. But if everybody's paying 40% of their health care costs, there's going to be a lot of bad debt in charity going forward.
Yeah, I agree with Dave on that. I asked my CFO, I said, you need to put this in perspective for our board and our employees. I said, if you look at the Affordable Care Act, the sequestration, which was a huge hit for hospitals, and the other changes in Medicare reimbursement, we're actually getting paid at the Thomas Health System $10 million less than we would have if they hadn't gone through. And I said, okay, now we're still in business. How do we do it? What are the add backs? And Medicaid for us was about $1.5 million of the $10 million. So we were going to get hit with the downside, so we had to get that extra $1.5 million. Then we got about another $2.5 million on something that the state's doing short term with Medicaid, but I think that's short-lived. It's called upper payment limit. We got some money on another federal program for putting computer systems in, but that runs out after this year. And then the rest of it just came, like Dave said, a couple years ago, we didn't have a salary increase for anybody at the hospital. We'd like to give salary increases that are greater than CPI, but we can't afford to. Payroll and benefits are your biggest expenses. So fortunately, we're growing. We're seeing more patients. So it's putting a stress on. But to answer your question, it would have been a real problem if the governor hadn't done that, and I commend him for doing it.
There's some good questions here, but what are your challenges in doctor recruitment, and how do you handle them?
Oh, they're huge. They're huge. It's always been an issue. And it's really switched. 5 years ago, almost every physician we recruited wanted to go into private practice, run their own shop. We, by law, could help them for 1 year to get their business going. We could help them financially, and then after that, they were on their own. Now, almost every doctor coming out wants to be employed. And I don't think there's 2 hospitals in America that actually break even or make money on employing doctors. So that's a new cost you're going to have to absorb in the hospital, but you have to have doctors because they're the ones that take care of patients. So like CMC and most other hospitals around the country, we're starting to have to employ them and try to minimize the losses on them.
Yeah, I would add to that that there's a national shortage of physicians. And that may come as a surprise to you, but the issue is that for the last 25 or 30 years or so, 52% of all the medical school classes have been female. As a general rule, when they finish medical school and do their residencies, they don't subspecialize. They don't go into gastroenterology or oncology or neurosurgery or whatever. They generally go into pediatrics, primary care specialties, internal medicine, family medicine, pediatrics. And again, as a general rule, once they start a family, they no longer work full time. So you have a situation, well, then add to that this new generation is just not going to work as hard as the previous generation of physicians. I see some smiles in the audience. I mean, literally it takes, the amount of call they're willing to take, the number of hours a day they're willing to work, et cetera, is less than it is today. So we're all scrambling, all of us are scrambling for the medical talent, the subspecialty medical talent we need to operate our sophisticated institutions. And I don't know how, frankly, the smaller hospitals and more rural communities will really survive in the long haul. I mean, this is another issue that the government has just ignored, frankly. More people insured, no new doctors really. I won't get into weeds. There's one more thing I don't want to get in. I'll get in the weeds anyway. Last year, there were about 1,000 more medical students looking for residencies in this country and could not find them. All U.S. grads. There were more medical schools, more doctors graduated from medical schools than there were available residency slots in this country. I mean, if that's not a national health policy issue, I'm not sure I know what is. And yet government so far has ignored it.
Okay. Related to the physician issue is the University of Charleston now has a physician assistant program, which we are glad to have. What role do you see PAs playing in healthcare as we go forward?
Well, I just tried to recruit every one of yours beforehand. I found their table, I went right to them, and I said, all right.
Why, you were passing out your card?
I left them in the car, but I would have. Now, if you're going to be a PA or nurse practitioner, I think the unemployment rate is going to be less than 0.5%, because that's how we're going to be able to have any chance to take care of these people. Something we're looking at Thomas with all the newly insured. Medicaid population generally doesn't have the resources a lot of other people do. They use the emergency room because they're usually on the bus route. A lot of these people just don't have transportation, and everything's there. The specialist is there, the primary care doctor's there, the lab's there, the radiology's there, so it's kind of one-stop shopping. And the emergency room is how they access it. So we're actually looking at establishing a clinic next to the emergency room, staffed by a PA or a nurse practitioner to take these patients when they come in. We still by law have to triage them and do a medical assessment to make sure it's not a true emergency, but say, obviously we'll take care of you here, but here's an option. And hopefully when they come back the next time, they go straight to the clinic, or the patients that get discharged that are particularly on Medicaid can't find a private doctor will at least have a trained person that will get to know them over time. So I think PAs, nurse practitioners, that's going to be that'll be the growth job industry in the next 15, 20 years.
Yeah, I agree.
What are the financial implications on teaching hospitals for graduate medical education?
Well, significant. We have about 177 residents. We do not make money, if you will, operating residency programs. For us at CAMC, any given day, we have roughly 500 students walking the halls of the hospital. We have the third and fourth year medical school students, which are about 40 a year, so about 80. We have pharmacy students walking the hall. We have PA students. We have nursing students, et cetera. Medicare traditionally, the program, insurance program for people over 65 and older, traditionally paid for graduate medical education. Well, over the last 10 years, they've continued to cut that reimbursement. So for us to even consider starting a new residency program, this is part of the reason why there was 1,000 medical school graduates that couldn't find a residency slot, is because it's so expensive to start a residency program that nobody's starting new ones around the country, and the government's not compensating hospitals for any new slots. So it's a growing expense, and with really no help, again, from the government.
This person says that many physicians refuse to see patients after a car accident. What's somebody to do when you can't get to a physician?
Well, if they come to the ER, we're going to take care of them. In private practice, I'd never heard that. I can't agree or disagree, but if they come to our emergency room or they go to Dave's emergency room, we're going to take care of them.
Somebody wants to know why CAMC did not sign a contract with Humana.
Well, we do accept Humana PEIA. We do not accept what they call Medicare Advantage patients by Humana. We had a contractual agreement with them that they broke, and so we decided not to do business with a company that couldn't keep their word.
Okay. How is inflation affecting your budgetary projections and expectations?
Well, pharmaceuticals, they always go up well above CPI, so that's, you got three major costs at a hospital. You got your people, you got your supplies, you got your drugs, and the drug costs are always the one that grows faster than anything else, and it's a big number. So then you got to say, okay, I'm not getting any more money from the government. I'm getting cuts over here. How am I going to pay for the drugs? So you just try to squeeze everything else. So it's an issue. Medical inflation for everybody out here that's on private insurance is going up a lot faster than CPI. All our employees, our own health insurance is going up more, and our input pricing is going up faster.
Yeah, I would just add that while no question what Steve said is correct, my experience is we're no different than any other business. I mean, all businesses are challenged to lower their cost every year, that their expenses go up faster than their revenues. I mean, just look at the state of West Virginia. There's, no new business, no new economy for the state, but yet you have inflationary costs. So you have to figure out what you're going to do. I mean, every business struggles with the same issue. We're so dependent on the government to compensate us that all we ask is that for Medicare, Medicaid, and PEIA, they pay us our cost. That's all we would ask.
And on that,
they haven't answered our.
I'm sorry.
They haven't agreed to do that.
Yeah, Dave, you talked about that earlier. If you look at your own health insurance, if you're privately insured, you're probably paying almost twice what you need to pay for your health care.
Yeah.
We have a metric we look at Thomas. If we bill out $100, what do we collect? And if you're commercially insured, we collect about 60 cents on the dollar. For Medicare, we collect 27 cents on the dollar because that's what they pay you. For Medicaid and PEIA, it's about 22 cents. So really, America is the only industrialized nation where private industry is subsidizing government health care. And if you have these huge companies, if they go overseas, the government pays for their own people, and sometimes they'll even pay for the company's workers. In America, it's totally flipped. All the people in private industry are paying for the government shortfalls, and that's, to me, unsustainable. And that, to me, is the biggest reason why, if you're privately insured, your health care costs are so outrageous.
Another question. As a consumer, I'm concerned that healthcare systems compete for my dollars. Can you envision a single system in which services are extended without having duplication?
I can envision it. I just don't see it happening.
They talking about insurance or about providers?
Well, it sounds like they're talking about providers because it says the healthcare systems compete for dollars.
Yeah, I would just make an observation here that under the Affordable Care Act, it makes a great deal of sense for some communities to merge hospitals. Huntington's the most recent example. Those two hospitals are trying to merge to really guarantee and ensure health care for their community going forward. The federal government, through the Federal Trade Commission and antitrust concerns, are worried that that's a bad deal for the community and for keeping costs down and so forth. They will end up spending probably millions of dollars trying to get an FTC approval. Whether they get it or not is just yet to be seen, but it's very difficult. So really the government policy is not encouraging the merger of healthcare facilities in a given community. Now, you could buy a hospital 100 miles away, but in a given community, it would be very difficult.
A question you might have expected coming from the audience. How prepared is the West Virginia healthcare system to deal with Ebola?
Well, I would say it's went from not even thinking about it to top of my agenda as the CEO in about 3 weeks, once that case happened in Texas. I think we're doing the best we can. If we get overloaded with these patients, we do not have the resources to do it. There's a shortage already on all the protective equipment that you need. We could handle maybe a handful at our facilities. I'll let Dave talk about his facilities. Nurses normally work an 8-hour shift, but apparently they can only work about 4 hours because of lugging the suit around and the stress and everything else. But in our facilities, we have designated areas. There's protocol that if someone does arrive at the ER, we get them into a secure space as quickly as possible. But I think this is something that at a lot higher level than Charleston, that we're going to have to dedicate national resources to make sure that as a country, if it gets out of hand, we can handle it.
Yeah, I would just add that really the best CDC guidance we received was last week. Friday this past week, we finally received a training video on how to don and doff, which means take off, the protective gear. I mean, virtually daily we're getting updates on the care of these patients, assuming we have them. So are we ready? We're as ready as we possibly can be. The reality of it, I'm sure, will show us that we're not entirely ready. The other issue to keep in mind is that the symptoms for Ebola are exactly like flu. The initial presenting symptoms, fever, nausea, diarrhea, vomiting, etc. And then the only way we have to really triage an individual that shows those symptoms is, have you been to one of the 3 countries in West Africa? I mean, that's what we're being instructed by the CDC to ask these 3 questions. If they haven't been, then we treat them like it's the flu. Now, we'll test for it and so forth, but it may take a little while before we find out that they have flu as opposed to something else. A colleague of mine just went through this actually over the weekend and had a patient that had been in Africa, had not been to one of these 3 countries, but had been in a neighboring country, was a really sick person. So they treated him like an Ebola patient, and it turned out he had malaria instead. But they geared up and went through everything just to try and be prepared. So we're concerned about the public's reaction when the flu season really hits, what the impact will be on the care providers, both in the primary care doctor's office, I know locally that there are signs on some doctor's offices that say, if you have a fever, go to the emergency room. There are other offices that are asking everybody in their waiting room, have you traveled in the last 21 days? Not whether you went to the 3 countries in West Africa, but have you traveled? And if you have, they're saying, we're not going to see you. So the sort of the hysteria is already there. And where I fault, again, the CDC and other public health agencies is that they've done a very poor job of really educating the public about the the real likelihood of contracting Ebola.
A very different question. Are patients using advanced medical directives, and does the use of these directives result in lower costs for hospitals?
I'd say they're using it, but not anywhere near as much as they should. And I don't think it does lower costs, but what it really does is keep your loved one from getting totally unnecessary care. I use the example of my mom. She was 85. She had been discharged from the hospital after some heart care up in New York. And 2 weeks later, went back with jaw pain on the left side. They totally missed the fact that she should have been brought in the back, and I am so grateful that that happened, because she was sitting in the ER reading her book, and she went like this. And she passed. And my sister-in-law was with her and finally realized it, and once they realized it, they dragged her back and they coded her for, 20, 25 minutes, broke 2 ribs. So that is not taking care of your parent. And that's what happens if you don't have an advance directive. The entire system is geared to keeping you alive, whether you want to be alive or not. So if you do anything, when you leave here, I'd say make sure you have an advance directive and make sure you get a flu shot, because that's going to truly affect how you're treated at some point in your life.
Would you say that the U.S. has more of a healthcare system or a disease management system?
Well, I think we have both. I mean, I don't know how to differentiate between the two, frankly.
Well, I guess
clearly
one system would be proactive, maybe.
Well, but the hospitals clearly are disease specific in that regard. But your public health system, inoculations, flu shots, I mean, all of those are part of the healthcare delivery system. The pharmaceutical industry, et cetera. So I think it's all kind of one and the same. We're a piece of that healthcare system. We happen to be the disease side of the system.
We live in a drug society. Many people take drugs for the rest of their lives and extend their lifespan. Some people are addicted to drugs that are going to reduce their lifespan and kill them. How do we try to manage the drug-oriented society that we live in?
Yeah, Steve?
Yeah, I have no idea. It's a huge problem. I go in our NICU, our neonatal intensive care unit, and it's always somewhere between 30 and 70% drug babies, meth babies, crack babies. Meth's a huge problem in West Virginia. A lot of opiate overdose, and they're in a unit that probably costs 4 to 5 times more than the nursery for the regular newborns that's right next door. So we have to address it. I don't know if it's more education. I don't know if it's more programs. I don't know if it's better enforcement. I don't know if it's prescription only for, Sudafed. We got to do something. But if I could answer that question, I don't know what I'd do. But I'm hoping Dave can answer it.
No, I really don't have anything, to add to that. I worry that we're creating, with the 30+% of the babies we deliver that have some sort of drug in their system, that we're creating a whole new generation of kids with learning disabilities and so forth that may have, probably don't have the best home life. As I said earlier, one of your big determinants of success in life and health in life is having environmental factors that will support you. They're starting off with a genetic problem already. They probably, the living environment's probably not good. I mean, are we just really creating the next cycle of people that are going to be drug addicted down the road. It's very worrisome.
I think you made reference to this earlier, David. More and more physicians are aligning with hospitals, and hospitals are employing them. Is that a good thing?
That's a really good question. Depends on the day.
Or the physician, maybe, but no.
Yeah. No, it's true. Hospitals are pretty much every one of the graduates from medical school, well, really residencies now, are being employed. They're being employed in an academic setting, in a teaching hospital kind of environment, large medical group, or a hospital environment. There are very few now that are going into private practice. Steve mentioned that earlier. It's a good thing from the standpoint that we need this medical talent to take care of people in our community. I mean, we have a level of care here that you'll find in any city in the country between our hospitals, and so we need the same kind of physicians that they have in Chicago or Dallas or Houston or New York or whatever, the same talent pool. And in order to get them, we'll have to employ them. Now, it creates a whole nother dynamic for us because, as Steve said, it's when we employ a physician, we manage much differently than they would in private practice. They get benefits, their employees get benefits. They're usually in a nice space. We've got a computer system. I mean, it's just more expense associated with employing a physician as opposed to a physician in private practice generally.
I'm hoping the plus for the patient. With our employed physicians, they're all on the same computer system, and it's much easier to interface it with the hospital system. So, as Dave mentioned earlier, you go to your doctor's office, they're going to order a test. They say, well, I was just at Thomas or St. Francis and I had the test. They can now pull that up in their office. So I think, and I'm hoping that there are some synergies here that are going to make it a more seamless system for the patient by having them employed by the hospitals. That's not going to cover all the additional costs, but it is a silver lining.
When one's assessing the quality of health care in a community, one is talking about more than what happens in hospitals. What are strategies that we can utilize to improve the quality of health care in a community or a region?
I think it goes back to what Dave said earlier. You got to look at your tobacco usage. You got to look at your obesity. You got to look at, are we living in a community that's conducive through public policy and through what's available to live a healthy lifestyle? And that's real hard. I know people that try to quit smoking. It's hard. I know people that try to lose weight. It's hard. But I think that's where it starts because, as Dave said, we sort of get everybody after the rest of the system fails, then they show up in our ER, and then they go fix them. And it's too late. We do the best we can. I think very few people leave America for better health care somewhere else. The richest people in the world fly to America because this is where you're going to get cutting edge health care. But if you wait till it gets to the hospital, it's too late to have a healthy community.
Somebody says, let's revisit cost shifting. What can hospitals, physicians, and others do to form a coalition to force the government to pay their fair share?
Good luck.
Well, I think I don't even know where to begin with that. We're constantly talking with our elected representatives. I know the physician organizations are doing the same thing. We're trying, but really to no avail. If anything, it's going the opposite direction, that they're continuing to cause the cost shift to become greater. If the Affordable Care Act was put into place to ensure that every American had insurance, you may have insurance. I can assure you it won't be affordable.
And I was just talking to a politician this morning, and they're wrestling. He's a state delegate. They're wrestling with the budget, and you look at their budget, and it's education and it's Medicaid, and they know they're underfunding Medicaid. So they got two choices. They could raise taxes. Well, how many politicians want to run on a package to raise taxes? About zero. You can't take it from education. So then you've got a small pot, to try to fix a big hole.
Right.
And so they just kind of say, well, we're just going to muddle along, and until business, I think business, they're the ones paying the bills, can really coalesce and say, this is the signature issue for business in America, is to fix this. I don't think we're going to move the dial.
Some of us may think we are taking it from education, but that's a topic for another night.
We'll arm wrestle for it.
Yeah.
All right. Well, our appetites are larger than our budgets all around. Mr. Ramsey said the system is broke in healthcare. So why do not CEOs of hospitals call on us to adapt Canadian or European style of healthcare?
Well, I think personally, I'd put everybody on Medicare. I'd say we're all equal. Now we got to figure out as a society how much we're going to spend on healthcare, as opposed to what we're going to spend it on everything else. But I think the healthcare system in America has been around for so long. The insurance industry is a huge component of it. People like having, even though it's expensive, they like having an insurance that their doctor says, hey, come on in, I'll see you today. So I don't think that's going to happen in my lifetime. But I think to me, that may be the best solution. I'm just not sure America's ever going to get there.
Yeah, I agree with Steve. I don't object to a system in that nature. I actually ran a healthcare system in Louisiana that did get a global budget every year. And it's in essence, a simplistic version of what happens in Canada is, if I got $1 million today to take care of everybody last year, and they give me $1 million next year for, plus 1%, 2%, minus 1%, 2%, well, at least you know how much money you have to take care of the folks that are coming through your door and what you can and can't do. That's where you hear about in Canada that people can't get a CT scan, or they can't get a new hip or a new knee or whatever. But to the point you made earlier, are we as a nation really going to tolerate that sort of scrutiny over our healthcare expenditures? If you live in Great Britain and all you have is their healthcare delivery system in Great Britain, and you're over 60, you will not get a new knee if you need a new knee, unless you have insurance to pay for it. If you have insurance, private insurance, you can go someplace and get your new knee. If you smoke and you need open heart surgery that's not emergent, they will tell you, we will do your surgery after you've stopped smoking for 6 months. Oh, by the way, we're going to test you every month. And if you have nicotine in your system, it's 6 months from then. It's a very different kind of environment than this country's used to. They would never do open heart surgery in somebody in their 80s, or do a hip in somebody in their 80s, or a knee in somebody in their 80s. That's totally foreign to their way of looking at the healthcare delivery system. Now, are we ready for that in this country? I don't think so.
Yeah, on that, you think there's an 80-year-old and there's 80-year-olds. My father-in-law had his hip done about 1.5 years ago, and we went to Ireland with him. His wife passed, and their family's from Ireland, and he was all over Ireland with a new hip. And if he was from Ireland or Northern Ireland, he probably wouldn't have gotten it. No. So, just because you're 80 doesn't mean your life's over, and you shouldn't be able to enjoy your family and enjoy the fruits of your labor.
Okay. Just a couple more things. One, if more doctors became concierge doctors, limiting themselves to about 600 patients each, would that improve the care for patients?
For those 600. Yeah. But for a typical family doctor probably has about 2,500 patients. So if they have 600, that means you do the math. You got 1,900 that are going to have to find a new doctor. And as Dave said, there aren't any other doctors out there.
Right. Yeah, if you can get in, if they'll respond to email, you can get in 24 hours, get them on the phone, that kind of thing, then yeah, it's going to be great for those 600 people if you have the right doctor.
Do you feel that a part of the high costs for healthcare are that in addition to seeing a personal family physician, everyone also needs to go to specialists?
Well, I don't think they do. I mean, hopefully you go to your family doctor and they send you to a specialist if you need it or not. If you feel like you're getting over-referred, I'd probably sit down with my family doctor, but I see my family doctor, twice a year, and, a specialist, I don't know, once every 3 or 4 years.
Yeah, I mean, really, that question is what sort of killed managed care in the 90s. We as a nation had tackled the healthcare delivery costs. It was flat to declining in the 90s. If you remember, that's the era of HMOs, and you went to your primary care doctor. You didn't get to pick whether you went to your orthopedic doctor or you went to XYZ doctor. Your primary care doctor chose what at the right point in time for you to go. Well, frankly, as a country, we rebelled against that. So we do have more people now, waking up and saying, I have a headache, I need to go see a neurologist or a neurosurgeon, as opposed to going to their primary care doctor. Or my knee hurts, I'm going to go to the orthopedist. Or I think it's time for my colonoscopy, and I'm going to go to the gastroenterologist without seeing my primary care doctor first. I mean, this country, we absolutely rebelled against being controlled on our choice of where we go to the doctor or the doctor that we want to go to.
Consumers, patients will need more access to information on the cost of services and the quality of providers. Will health providers be willing to publish the costs of services and health outcomes for patients to comparison shop?
I think a lot of it's public. I mean, our charge master's public document. Now that nobody can read the thing, it's probably that thick. But if you're coming in for a knee or a hip, we don't know what it's going to cost. I mean, we don't know if you're going to be in the OR for 1 hour, 2 hours, 3 hours. We don't know what the surgeon's going to find when he gets in there. He may have to say, well, I'm going to use a knee or a hip that costs $2,000, but when I get in there, I can't use it. I got to use a $4,000 hip. So it's, it's not like buying a car. I had a doctor, I had a chemist on my board arguing with a doctor, and the chemist said, we take a chemical, we heat it up to this temperature, under this pressure, and it pretty much reacts the same every time. And the doctor says, I have 2 patients, they could be twins, weigh the same amount of money, I give them the same pill, and they both react differently. So I don't think we'll ever get to the point for anything beyond a chest x-ray or a mammo where you can say, here's our list price. You just don't know.
Last question, I'd like for each of you to articulate kind of what's your dream for the future of healthcare. What would you like to see happen that you think would be, is feasible on the one hand and would be extraordinarily helpful?
Saying healthcare or hospital care?
You can define it as more narrowly if you wish.
Well, I think really the tenets of the Affordable Care Act is what everybody that's in this business would like to see happen. I mean, all of us got into the nonprofit healthcare business to try and do good for society and take care of people, and no one works at CMC that doesn't have that idea or mission. So could everyone come see us and with no question about having to pay for it? I mean, that would be utopia. That's never going to happen, but that's what we would all like to happen that work in this industry. We'd like for everybody to take care of themselves. As I said earlier, only 5 or 10 to 15% of what we do in the healthcare delivery system has any impact on a person's health and well-being. I mean, if everybody would just take care of themselves, it would be a far better world that we live in this country. So, we'd like for everybody to have access. We'd like for everybody to take care of themselves, do what they're supposed to do, eat what they're supposed to eat, don't smoke. All the behaviors we know we're supposed to do, and we'll probably be much more healthy than society is today. It's hard. I'm sitting up here and I'm saying these words, but I'm trying to deal in the back of my head with the reality of what I have to, deal with in our system. So it's hard to think in this fashion, realistically. But really, bottom line is everybody would take care of themselves, get their flu shots, get their inoculations, et cetera. That would be the best thing that could happen to healthcare in this country.
I agree. I was going to say tobacco usage. If we could significantly reduce it or eliminate it, that would probably have a bigger impact on anything else. And obesity, I think it comes back to personal responsibility. But we've been working on that for a long time, but we're making progress. The bad numbers are going down and the good numbers are coming up, at least for tobacco use. Obesity, I think they're still going, maybe they've leveled out.
Yeah. Well, I thank you both. 2 weeks from tonight, we are going to have another presentation, as you heard, Jim Conway, who is an adjunct professor at Harvard and the former senior vice president of IHI. We'll be here to answer these questions and others, so you're invited to come back. It seems to me that Steve and David have both been candid, informed, knowledgeable, and sharing their views easily and comfortably, and that we're fortunate to have them leading the hospital systems here in our community and helping out to maximize what healthcare is. So thank you both for being here and answering all these questions tonight.
It's been a pleasure.
Thank you, sir.